All right. One of the things we do as a CHNA is to reinvest resources into the community and towards our goal of achieving improved health outcomes for residents of our region. And we always like to hear back from our grant recipients about what they've done with those resources and the change that they've been able to accomplish. So we are going to have a mini grant outcomes report today from the Health Imperatives WIC program. And we have Jennifer Allison, who's the VP of Development and Community Relations for Health Imperatives. And I think Rose Hamilton also. If Rose is on. Oh, hi, Rose.
Yeah, Rose is here.
I'll let you folks introduce yourself, but we're excited to have you here to talk about that grant. Thank you.
Okay, thank you so much. So I am Jennifer Allison from Health Imperatives, and I'm going to kick things off here. And I think we're going to share a few slides with you just to give you some visuals of what we have done thus far. There we go. Great. And actually, I'm going to get things rolling by providing just a little bit of background information about Health Imperatives itself to give you some context as we talk about the specific project that we're carrying out. So Health Imperatives provides sexual and reproductive health care, nutrition assistance for women, infants, and children, about which you'll be hearing more throughout this presentation, and then home visits and other supports for young parents, and a number of services for survivors of trauma and violence, including an emergency domestic violence shelter, a rape crisis program, a hotline for survivors to call, and then medical and legal advocacy services. And we have 7 locations across southeastern Massachusetts. And most fundamentally, we focus on helping low-income, vulnerable individuals and families to become healthy, safe, strong, and empowered. And you can see our tagline there at the top of the slide on the upper left. So in July, with funding from South Shore Community Partners in Prevention, we began an outreach campaign for our Women, Infants, and Children nutrition program in Plymouth. And if we can just flip to the next slide, I'll tell you a little bit about that program. So it basically provides free healthy food, breastfeeding support, nutrition counseling, and referrals to a wide array of community resources. It serves low-income, pregnant, breastfeeding, and non-breastfeeding postpartum women, infants, and children up to the age of 5. And the requirements of the program are that families be at risk of not receiving adequate nutrition, and that they have an annual income that's at or under 185% of the poverty level. And just to give you some sense of scope here, in fiscal year 20, this program served right around 2,000 individuals altogether. So next slide. We decided to conduct an outreach campaign focusing on WIC, first of all, because we felt that obviously good nutrition is essential to good health. So it's, this speaks directly to our mission to get more people engaged in this program. And then we also understood, and we were really concerned that there are a lot of families that are eligible for the program, but they're not accessing WIC because they're not familiar with it and they don't necessarily know how to apply. So for example, the state's WIC needs assessment showed that in 2018, in the 11 communities that are part of South Shore Community Partners in Prevention's catchment area, only around 35% of the individuals who are eligible for the WIC program were actually receiving those services. And we also understood, of course, that the number of families who needed WIC was rising rapidly as a result of the COVID-19 pandemic, and that some families who had previously transitioned out of the WIC program would need to re-enroll as a result of lost income. So we wanted to make sure that those families as well knew that the WIC program was still there for them. So as you can see here on this slide, we had 2 major goals for our campaign. And the first was to create new materials using a variety of methods to reach all of these families. And then the second was to make the messages contained in those materials really accessible and easy to understand, so they would be helpful to people with limited literacy. The WIC program is somewhat complex. It's a little bit bureaucratic, and we wanted to cut through that and really help people to understand very clearly, very simply what the program could do for them and how they could participate in this. So next slide. So we created 4 sets of WIC flyers and fact sheets to provide key WIC information. And I think if we just go to the next slide, we'll see some examples. There they are. There's 3 examples of fact sheets that we did. So the materials were organized so that each set of flyers and fact sheets covered, a topic that we felt was really critical for people to understand more about. So we divided these 4 sets into, first of all, an overview explaining WIC services, so people would really know what the program does. And then secondly, a little primer on how to enroll in WIC to kind of demystify this process, so people, it could be broken down into simple steps and people would not be confused or hesitant or about being part of the program. And then third, a list of tips for healthy eating that included things you can do to, stretch your budget, and a list of breastfeeding tips for expectant and new mothers. And so you can see examples. We not only created hard copy materials, but we also did social media outreach. You can see examples on this slide of the healthy eating tips and advertisements that we did. So we knew, obviously that creating these materials, it's just one part of the process. And it's also necessary to get this information into people's hands directly and onto social media. So each flyer and fact sheet is being distributed throughout the community. We've done Facebook advertisements, boosted posts, a series of 10 Facebook posts on healthy eating tips altogether. Again, really to use all the means at our disposal and get as much information out to as many people as possible. And then let's see, next slide. We also did, there we go. We also did a press release as well as posters promoting WIC services, and these were displayed on buses in the Plymouth area. And we worked with PAC TV in Plymouth to do a public service announcement. And actually, I think we're going to put a link to that PSA in the chat box so everyone can check that out. So that, in a nutshell, is the core of what we did. And then I'm going to turn things over to Rose at this point so she can share a little bit about the results thus far.
Thanks, Jennifer. Yes, I wanted to share a little bit about the second, also just to underscore the second objective in this campaign, which was to make the information as accessible and easy to digest, if you will, for the folks that we were trying to reach. So as Jennifer mentioned, we took the whole WIC message and broke it into 4 mini chunks, almost like mini campaigns, if you will, and she outlined what they were. So that way we were able to really keep the language for each of the flyers or the Facebook posts very simple and straightforward. We used phrases such as WIC can help you, very simple to catch people's attention. And we used those headlines consistently across the printed materials. We also made sure to use a consistent look and feel so that as these different printed materials rolled out, they would start to be recognizable and familiar that this is WIC related information and you can get help from WIC. We were also consistent with the color palette to be recognizable. And really importantly, we made use of a lot of icons to correspond with the text that we were sharing with people, to be another point of entry, to help with health literacy, and to support the text. So, an apple for healthy eating. There's an icon of a woman breastfeeding. There's a refrigerator and freezer about freezing your food. So these are all aids, if you will, to help folks who are reading the information. We also, on the printed materials, made sure to provide multiple points of contact so that people could reach us for additional information. We put a phone number, very prominent, with the phone icon. We have the URL to our website, and we also have the tear-offs if somebody wanted to grab a tear-off and get in touch with us later. And with all of our Facebook advertising, we would include the phone number in the text of the ad. And of course, if they click on the ad, they go right to our website, which has a section devoted to WIC. Just a couple things on the results so far. So far, we have produced and distributed 3 pull tab flyers and 3 fact sheets. And Jennifer mentioned they're kind of like sets, if you will, or mini campaigns. So each one of the mini campaigns includes a fact sheet, which has a detailed description of what the particular focus is of that campaign. And then the flyer is a pared down version of that with the phone number and contact information. We did 3 Facebook ads and 5 Facebook boosted posts, and we've done 10 Facebook posts providing healthy eating tips. The printed materials have been distributed throughout the greater Plymouth area. And, you know, during COVID-19, it's a challenge to find the best places to get that information to. It's obviously more limited than at a different time in our lives, but we were able to get it out to many different places, a lot of pediatrician offices where we know new moms, babies are going to be. And for all of the printed materials, we produce them in English and 4 additional languages: Spanish, Portuguese, Cape Verdean Creole, and Arabic. Our program staff in Plymouth were able to provide us with the information of how to best reach people with those languages. And just a couple other things on Facebook results. So we've done 3 ads, which have reached close to 78,000 people. And of course, in the world of Facebook, when you say reach, that means it's gone out and it's been on somebody's screen. We hope certainly that they did actually look at it. 5 Facebook boosted posts, a little over, well, close to 17,000 in reach and 300 clicks. And our series of 10 healthy eating tips reached 753 and had about 45 clicks. We will be launching the 4th and final mini campaign later this week. Actually, the printed materials will be going to the printer, and then we will do the corresponding social post with that. So we anticipate these numbers going up. We believe that the total advertising reach will be on Facebook will be around 100,000. The Facebook boosted posts around 20,000, and the healthy eating tips are actually done. So that would stay at around the 753. And as Jennifer mentioned, one of our favorite parts of this campaign was doing a PSA. We worked with PAC TV, and it's really a wonderful look at what WIC is all about. I would love to play it for you right now, but we found that sometimes when you play a video and sharing with screen sharing on Zoom, it doesn't go well. So I don't want to do that. And what I'll do is I'll just put the link in the chat, and you all can look at it if you have the opportunity. And I think that's it.
Great. Thank you, Rose, and thank you, Jennifer. Couple of comments I have. Great to see that you're sharing these messages in multiple languages to make sure that it's getting out to as many different communities as possible. And, you know, the beauty of social media is you can quantify your reach as you did through Facebook. But I wonder if you've seen an accompanying increase in either inquiries about the program in person and clientele increase as well.
Yeah, we're looking at that. And thus far, I would say what we've seen is that our monthly active caseload is around 10% higher than what it was at the same time last year. So we are seeing an increase, and we hope as these materials continue to roll out, we're going to keep using them to generate interest in the program. We hope that those numbers will increase still further.
Great. And I wonder, do you think the caseload increase has, have you seen any impact from COVID in terms of your caseload?
Yeah, we have seen numbers go up, of course, as a result of that as well. And we have had a lot of people who have re-enrolled in the program. They had initially transitioned off after receiving assistance for a few months, were able to find employment, things were going better. And they no longer needed the assistance. But then unfortunately, as a result of the pandemic and the job losses that have occurred, a surprising number of people have re-enrolled for services.
Yeah. Great. I don't know if anyone else has a question. Maybe if we can, I'm going to stop the screen share if I can. No? Okay, you stopped it. Thank you. Does anyone else have a question? Oh, Blake, go ahead.
We're also, so my name is Blake. I work for Plymouth County Extension. We're also trying to distribute educational materials and such. I'm curious about who did you hire for to translate your materials into different languages? Because right now I'm looking into doing that.
Oh, that's a great question. So we work with a company called Language Line. It translates the materials. And then we also, since we're very fortunate to have many staff people at Health Imperatives who are bilingual and multilingual, we're able to have them review the translated materials, just to check, make sure everything is the way it should be. So we sort of utilize both of those resources.
Thank you.
Great. Thank you. Any other questions? It's such a big group, I have to toggle between screens here to see how many people. If anyone has a hand raised, I don't see any. Jennifer and Rose, thank you so much. We're excited to hear back that the campaign has met with some success, and we look forward to hearing more about the program as time goes on.
Thank you.
So
Thank you.
thank you. Yeah. So we are very excited to have our main speaker come and talk to us. As we all know, today is the 1-year anniversary of the declaration of a state of emergency here in Massachusetts. I wrote down the numbers and now I can't find it with all my notes. Here we go. Over 560,000 cases in Massachusetts and 16,000 plus deaths. So we've seen a huge impact just physically from COVID, but we also know that there are impacts on mental health and behavioral health. So we're really excited to have Commissioner Brooke Doyle from DMH here to talk about what some of those impacts have been and what we as providers and caregivers should be thinking about as we look forward to the post-COVID world and what that means for behavioral health. So Commissioner Doyle, thank you so much for joining us, and I'll turn it over to you.
Thank you. I appreciate the invitation to come here today and just want to acknowledge my NAMI friends who invited me. So thank you. It's wonderful to join you all this morning. Appreciate the interest that you're taking in a holistic view of the health of your community. And Michael, you had sent me a few key points that you were hoping I could touch on today. And I sent around in chat a link to some slides that are publicly available on EHS's website. I'm gonna try to share those in a little bit, but I should be better at this point than I am, but in case I have technical difficulties, I wanted you to have a link to the slides. But I will make an effort to share them with this group in a few minutes. Just wanted to touch on a couple of high-level points before I go into slides. First, just want to say that the effort that you all are making, and just want to reinforce the concept of holistic care. Truly appreciate the effort to bring me here today and to talk to all of you about behavioral health in general and mental health specifically are critically important. And just want to highlight a couple of areas of interest of mine, and to say that when I speak about mental health, I generally speak about both mental health and substance use disorders together, because it's very common that people experience conditions as a whole person and not as siloed needs. And we sometimes don't always deliver care as a holistic behavioral health care system. And so one of the things I'm going to touch on in the slides is some areas of improvement and reform that we're looking at to address that particular challenge in our healthcare delivery system. In terms of COVID, yes, COVID has had an effect on the behavioral health of our communities in probably every way that you can imagine. Stress, loss, grief, the financial pressures that people are under, the exacerbation of trauma for people who may have already had vulnerabilities for trauma, depression, anxiety, isolation, caused huge impact to people. Early in the pandemic, we actually saw that people were staying away, following the advice of that 1-year anniversary to stay home, take care of yourself. People did. They didn't go to seek additional help. We saw that there was a precipitous drop in help-seeking activity during that time. In that time, providers pivoted really quickly and adopted telehealth strategies to try to respond to the experience of more people staying in their homes and to make access as possible for people as it could be. What we saw, and the Health Policy Commission recently did a study of this, the behavioral health space actually increased its telehealth capacity at the highest rate of all healthcare during this pandemic. And that's something that I think we'll see will continue post-pandemic as well. And what we did see is that telehealth became a lifeline for a lot of people. Over time, we also saw that some people either weren't able to access because of disparities, or it wasn't the right modality for some people. And so what we're learning going forward is that behavioral health will always need to be, at least in some measure, in person. And that's to make sure that we're reaching all people. One of the other indicators that we saw that contributed to some of the learning along the way is that after a couple of months of isolation, people did start showing up to seek help, but they went to EDs, and that pattern is continuing. Emergency departments are seeing extremely high rates of demand for behavioral health intervention. At some points, it's been as much as 200 to 400 times higher, depending on the emergency department that you're in. So that also showed us that it was critical that we figure out how to reach people in their communities. The slides will also talk about some of the reform that we're doing to strengthen the types of services that are available in communities for people. And these are things that we are seeing that in some ways were pre-pandemic issues, and during this pandemic period has only heightened the urgency around the need to strengthen behavioral health services in our community and to close some gaps. And one of the areas where we know there was a pre-pandemic challenge, and it certainly has persisted during this time, and Michael, one of the questions you asked me to talk on was ED boarding and what we're doing. So emergency department boarding in response to more people seeking help has resulted in more demand. But more demand is only part of the story, because the hospitals also had to start putting infection control procedures in place. And so in some hospitals, they had to do some social distancing spreading. So where they might have been able to have double occupancy rooms, they might have had to reduce down to single occupancy rooms, depending on the square footage, which created some adjustment in the numbers of beds that were available. Like I said, there were certain segments of the hospital service population that were already experiencing some strain pre-pandemic. And then during pandemic, we also had some natural experiences that contributed to bed closures. Norwood Hospital, you might recall, had a flood. And that was a location where we had a significant number of inpatient beds for psychiatric inpatient treatment. One of our other hospitals in Western Mass had closed, and that was due to staffing shortages. So there were a lot of contributing factors that led to why beds were harder to access. And then periodically, there were outbreaks in different hospitals, as there may still be going forward, because COVID's still with us. And when there's an outbreak, you have to limit admissions to certain settings. All of these things have contributed to why wait times have been exceptionally long. In terms of what we're doing, we are working with our hospital partners that have the resources to expand capacity, and we're actually increasing bed capacity with certain hospital providers. And the Commonwealth has created incentives for development, bed development. So hospitals that have the capacity to help build these beds can qualify for incentives. And the Commonwealth, this is an area that I think Massachusetts should take some pride. We're one of the few states that made an investment in this area. So just want to call that out. Our state actually did quite a bit to invest in behavioral health services during this pandemic period, including allowing telehealth to be billed at the same rate as an in-person encounter, and also making audio encounters billable. So these were things that were really done to ensure that people had access. I am going to try to share now. With any luck, this will work.
The slides are in the chat. Is that correct, Commissioner?
The slides are labeled behavioral health reforms, helping people access treatment when and where they need it.
Okay, you had put in the chat the roadmap.
Yep, that's the one.
Okay, oh yeah, ensuring the right treatment when.
All right, let me try one more time to see if I can load this. All righty, let's see. There it is. Can you see it now?
Yep, I think we're good.
Oh, good, good. All right, thank you. Sorry for that.
No problem.
All right. So, I'm just looking for my controls. Here we go. These reforms that I'm going to share with you are based on some listening sessions that we had done. We had actually started this planning back in 2019 and got a little bit sidetracked with COVID, but we had received feedback from nearly 700 people. We went all around the Commonwealth to collect information. And some of what we heard, and probably won't be a surprise to most of you, is that people often don't know where to start to get help. And even when they do start, they learn that maybe their health insurance isn't accepted, or they get to wherever they've been referred to and it doesn't have exactly what they need. Or that they, as I started off saying, they can't get mental health and substance use treatment in the same place, and now they have to start in 2 different places. Or there may not be culturally competent or linguistically consistent resources. And so all of these contributed to some of the historical challenges that we've seen. As we've started talking about, I won't go over these same points again, but the pandemic has only heightened the urgency. And we're very grateful that the legislature has actually codified the health insurance coverage for telehealth for behavioral health going forward. So these are things that will stay with us in the long term. Among Mass Health members, 75% of the visits were happening via telehealth during this pandemic, and some providers actually experienced about 90% conversion to telehealth. So it was a big impact. And one of the things that we definitely saw, as I mentioned earlier, is that it worked for some more so than others. And the Health Policy Commission's report, it was able to highlight some of the population segments that didn't tend to lean into telehealth. People over 75, and apparently young men. So not sure, what that was about, but they tended not to stay in treatment, and young children. So it was both ends of the spectrum and young men. So what are we going to do about it? I think a lot of these things may just seem intuitive or entirely known to you. So the question is, what are we going to do about it? One of the things that we are planning as part of our reform is to create a centralized front door so that people actually know how to start, because it's not good enough to just say that help is out there if you don't know where to go to get it, and if it isn't actually easy to access. So we want the help to be easy to reach. And so what we're talking about here is a centralized call center where a person can use one single call line and get not just information and referral, but a triage and navigation function as well. That leads them to what will be a new provider type called a community behavioral health center. And in that new provider type, there will be urgent care, same-day access, and crisis care. So under one provider type, again, removing some of those parallel systems where crisis operates by itself and outpatient operates by itself, and we never had an urgent care function. We have some same-day scheduling, but not across the board as a standard. So these become standards, and all of these standards apply to treatment across the lifespan: youth, adults, and older adults. The community behavioral health centers will be dotted throughout the Commonwealth, and they will actually be wedded within the existing system. So we actually expect that many of our providers will seek to become a CBHC provider type. We don't envision that this is to replace the existing system. It's to fill gaps. And with that, one of the gaps we know exists is behavioral health resources integrated within primary care, fully integrated. So there's going to be some resource that will be built into primary care as well. And I already discussed the expanded inpatient capacity, and what we're designing there includes some rate adjustments to ensure that these beds that are being added for capacity can remain with us, and that it isn't just part of the emergency response. Some of the principles that we built into this are to advance health equity and to ensure that members of diverse communities and families are able to get their needs met. We know that we have not always reached into communities very evenly or effectively, and so we do intend to have that as a standard. There are going to be very high bars for these CBHCs to meet, and we intend for them to meet them. So we know going into this, and we're communicating that out to everyone who might be considering becoming a CBHC, that it may require partnership arrangements, not just a single entity to do all of this. Some may have this full capacity, and we welcome that vision as well, but we also understand that this may require partnership. We want to encourage full acceptance of all insurances, so we're working hard with the commercial payers to make sure that they are included in this. And we also want to broaden health coverage for behavioral health. By that, we mean the inclusion of certain types of titles that hadn't always been able to be covered, like certified peer specialists, expansion of recovery coaches, and making sure that titles that have historically not always been part of the CMHC package are included. We want to make sure that we're expanding workforce diversity and competency for evidence-based practices. And we also want to make sure that these resources are built into communities so that people can get treatment when and where they need it. And that includes restoring crisis back to the community. It has become a function that often gets assigned to do level of care reviews. And our intention with this new provider type is that crisis will be restored back to a community function and will be able to mobile out. We are envisioning crisis service to include crisis beds for youth and adults. We've never had crisis beds for youth before, and we're envisioning a broadening of that scope of service. Over the next 3 years, we're anticipating that the public expenditure in Massachusetts for this type of intervention will be increasing by over $200 million. In order for us to be successful with this, we know we need all insurers to cover this. So we talked about some of these principles, but just want to highlight a couple of key points just to reinforce them, that integrating behavioral health has to be part of the solution. You know, I find it ironic that we talk about integration and it's often conceived of as physical health and behavioral health, but we really do need to work at integrating substance use and mental health treatment. And there also needs to be a no rejection option. People need to be able to get treatment regardless of what their treatment history has been. So we talked a little bit about the centralized front door. These are some of the structural supports for access. Want to also make sure that provider networks are being expanded, that there's administrative simplification so more people will join the networks, and that the competencies that are required for this provider type are inclusive of evidence-based practice and being able to meet the needs of diverse communities. We talked about the treatment services that we're adding in being the urgent care capacity, the crisis stabilization for youth and adults, and also more access to 24-hour substance use disorder treatment. We envision that there, in this vision of full integration of substance use disorder with mental health services, that people can get induction into MAT at any point in this journey, this treatment journey. You don't have to go to a special place. The important piece about our front door, what I want to stress is that we envision that this is a clinical triage and service navigation. We understand that we need to be able to have this capacity in multiple languages to truly meet the need. We also understand that this is going to take us a bit of time to stand up. So this is not going to be an immediate change, and we will be leaning in on some of our existing helplines to help during this period while we're designing the centralized front door. The CBHCs and integrated primary care will have the opportunity to qualify for value-based payments. Can't stress enough what kind of a sea change this will mean. It will move behavioral health out of a fee-for-service payment landscape and into a value-based payment, which will allow them to provide treatment in truly a person-based way and not a way to just ensure that you're meeting all of the terms of payment requirements, the contractual requirements. This will allow us to bring in other titles to help support the work that's being done and for licensed professionals to work at the top of their capacity. There are some other priority populations that we know require specialized support: autism spectrum disorder, intellectual disabilities, and also justice-involved populations. It's really important to us that we shift the locus of where people get their care out of the emergency departments when possible and into our communities. We know that emergency departments will still be needed, so no one's suggesting that it wouldn't be appropriate to go to the emergency department when that's the right place to go. We just want to make sure that people know that there are other options for them to meet their needs. In terms of advancing health equity, we talked about this being both multilingual, but also understanding that our deaf and hard of hearing members need to have access that's specialized as well. The administrative simplification that we're talking about, it includes standardizing the credentialing process. There's also some work that's being done through the 1115 waiver review that would include a single broad provider network and looking at the development of a single contract for behavioral health in the public system. We want to make sure that provider directories are accurate and updated. We talked about telehealth and the importance of bringing in recovery coaches, peer specialists, independent psychologists, and social workers, and to work with the commercials. So how is all of this going to get done? That's a lot of work. Just want to acknowledge that it is going to take us several years to get this done. It's not a single year project. So our roadmap includes some things that will happen in the near term, some things that will actually happen over a longer period of time, and then ultimately where we want to land. Some of this requires that we get approval from CMS, and that's part of the 1115 waiver review that's being done right now with our Mass Health partners. This is a cross-agency initiative. This is not a DMH initiative. I just want to stress that. We've been working closely with DPH, BSAS, Mass Health, DYS, DCF, every public agency that exists, and our stakeholders. So just in summary, we know this is going to cost extra money. And I am grateful to say that I'm part of a state and administration that takes this seriously and is making these investments. We all should take some pride in that. The public sector investments are, as I said, building on our system. So this is on top of everything else that we already are investing in. So anyone who might be interested, there is a Q&A session coming up next Monday. You're welcome to log in and join on, and there's a registration link here included. And I'll stop sharing and open up for any questions or comments or thoughts that people might want to share.
Great, great. Commissioner, thank you so much. A lot to digest in that, in all those slides. And I think that's available on the mass.gov website. Is that correct?
It is, yep. And
That was a link, yeah.
Yep, and
So,
the link takes you right to that place in the website.
Right. I know, Teresa, you had said you had some questions, and I think you're unmuted, so go ahead. Teresa Harmon?
Hey there. Yes, I had a couple questions. So I'm actually a social worker involved in integrated primary care. I'm an ACO social worker. So, familiar with what you're talking about. And just from my perspective, one of the things we're really struggling with, I'm sure across the state, but here on the South Shore, we're really running out of providers to refer patients out to in an interim until this kicks off over the next couple of years. There's just no one to send patients to any longer for one-to-one therapy. So I don't know if you have any comments on that, if there's anything in the works there. I don't know if there's any initiatives that you guys are working on to kind of provide incentives to new mental health professionals that are in school now, psychiatry as well, if you can comment on that.
Yes, happy to comment on that. The roadmap does contemplate some investment in loan repayment options for targeted, hard to fill positions. And we also want to use that opportunity to build the workforce in a more diverse way. So social workers, psychiatrists, absolutely included in that. In terms of building capacity now, the CBHC that I mentioned, the Community Behavioral Health Centers, the procurement for that provider type will actually be going out this spring, and the value-based payments can actually start. We don't have to wait for waiver approval for that. So even though it might take some providers more time to stand up their solutions, we envision that the rollout of this will likely occur in 2022, just to give providers enough time to stand up and make the changes that need to be made. But during that time, we're envisioning that there will be some expansion of their workforce. And the solution for expanding access, from what we've heard and seen, is both tied to some of the administrative simplification that we talked about to make it easier for more providers to join into the networks. Massachusetts actually has more licensed professionals than any other state, and we train more people. But what's missing in this equation is that these licensed professionals have often not opted into provider networks, and they take private pay patients instead. So we're trying to address the barriers and make it more feasible for them to enter into network. We believe that we have more workforce out there than is entering into network today. So some of what we're trying to do is to solve that and build on our capacity that is already here while we're also expanding the workforce at the same time.
I have a question, if you don't mind. Thanks for your presentation, Brooke. I was curious, the barriers to becoming a provider that accepts a certain kind of insurance, I don't have a lot of background or understanding on that. Like, what would make a provider not want to, or kind of like stutter step from getting into a certain insurance?
There's a number of different factors, and different providers may land in different places of what is their lead barrier. So I'll just list out what I know to be the barriers, and just want to acknowledge that it isn't a single issue or the same issue for everybody. And some of it is the historical framework, as I mentioned, that certain provider types just weren't even allowed to access in. It's just they weren't covered. So some of it is about addressing that and broadening the coverage to make sure that they can be included in. The other realities are that payment levels were sometimes a barrier for people. They viewed the payment level as too low, given the amount of effort that they would need to put in. In some instances, it's credentialing challenges. Credentialing is required in order to become part of network as a covered provider. And there's some administrative requirements to make that happen. And for some providers, the need to actually enter several different credentialing forms to be in network with multiple payers, and then track renewals for all of that, felt, especially if they didn't actually have an office staff that handled it, was a lot for some people to take on.
Yeah, that makes sense. Thank you. Just personally, you know, I always wonder when I go to a certain provider and they're out of network or don't fall into something I didn't really know why. But that was great. Thank you.
Just sort of on a related note, thanks, Kelly. You mentioned in the slides, Commissioner, that there's a pretty significant public sector investment through the governor's budget over the next few years, but also that in order for the whole plan to work, there needs to be investment and engagement with private commercial insurance providers. Can you speak to what the process is with that and how far along that engagement process is?
Our cross-agency work team has already started engaging the commercial leads to brief them about what is possible with this roadmap that we're envisioning, and also encourage their participation. Part of why I wanted to bring that out here is that many of us are covered under commercial plans, and we want to make this resource robust enough that it's something we could all access. To Kelly's point, if the CBHCs are out of network for the commercial plans, that urgent care option wouldn't be an option. And I can tell you, I just had a call with a family member yesterday, and we were talking about this urgent care capacity. Their family member had to go to an ED. They were trying to intervene in a crisis earlier than they had previously done, because his family member had been hospitalized about 2 months ago, but was experiencing some breakthrough symptoms that hadn't quite stabilized yet, and was trying to intervene early enough to avoid a longer hospitalization or more risk. And they had to go to the emergency department, and they were wishing that they had an option that they could have gone to at the time when their family member was agreeing to do this. So it just didn't exist. And they believe that their family member could have been safe in a community-based urgent care environment, and entirely possible that that ED experience could have been avoided. And it was an unpleasant experience for this person. And I regret that. I regret that he had a bad experience, but he is getting his treatment now. Just want to assure you of that. But it's, you know, I believe that if more of us can get out and speak to our plans and let them know that we're interested in having this full broad array of services available to us as part of our covered service plan, it will go a long way. If they know that their members really want this, it will go a long way to ensuring that they actually build it into their covered service plan.
Great, thank you. Kathleen?
Why do I always forget to turn that on? Good morning, Commissioner. Thank you for the presentation. This is the second time I've heard it, and it really all, you know, hit the gray matter today. You did it in such a calm, laid out kind of way. I really appreciate it. And I think it's going to be awfully good. My question is, as far as providers, and this is a tricky question, so I hope everybody will forgive me that. finding a therapist is difficult, as you know, people have said. But we do have a service in Massachusetts that is offered by William James College, the Interface Referral Service. But it is so expensive for towns to be able to subscribe to the service. And so with the money, the public money that's coming into this program, or new money, I guess would have to be, because this money is going to send so many good things. You know, something has to be done to help the towns and not have to pay for this, especially now that we're coming out of COVID. And I just wonder if there's any kind of arrangements that can be made for the public-private kind of service. That's a big order, I know.
I appreciate the question though, Kathleen, because it's entirely what's focused in the centralized front door concept. And it will take us a little bit of time to get there. But what we really would want to see is that anyone could call and get that navigation. So if what they were seeking was information and referral to assist somebody in your community, you should be able to get that, as well as helping the person link into the centralized front door so that they can receive that triage and navigation. I think the key here is that every resource that we have to date, William James is one, there's Network of Care, which is another one. They give you a link into finding a resource, but they often don't have updated provider networks. Sometimes you get there and you're not always sure that it accepts your insurance. And so there are still gaps in the way these resources work. And we want to make sure that the front door really does lead to a meaningful intervention for the person. And that's why, for at least for our concept, what we've envisioned is that the front door at a minimum can lead somebody to our urgent care and crisis service, so that their needs can be met in real time. And then that navigation work that you're talking about can continue. So if it's not an urgent care need, but the need is navigation and assistance with getting an appointment, that can also happen. If they don't have a provider now, they could be assisted in linking in through the centralized front door and the CBHC.
Excellent. Thank you.
Forgot to unmute myself, Kathleen. Thank you so much for the questions. Any other questions? I really appreciate. Oh, sorry, Tyra, go ahead. Yep.
That's okay. Good morning, Commissioner. Thank you so much for being here and talking about these things. It's really good for the public to hear what's going on behind the scenes. It gives us some confidence and some hope in what's to come. My question is really geared towards the caregivers. My concern is that usually when trauma or a situation happens, people are brought in from another area that have not been affected so that they can provide proper care. COVID will not give an opportunity for providers who have not been touched by the scenario, the situation, to provide care. What is within your plan? Are there plans to provide care for the providers? You know, providers are also being traumatized and going through, and my concern is that we're going to see an influx of people retiring, leaving the field, or finding that it's too stressful. What is being done to care for the providers and the people on the front lines?
Appreciate that question, and it's really an important one. I want to let you know about a resource that exists today to do exactly that. It's called Mass Support, and Mass Support is operated through Riverside's Trauma Center, and it is supported with a grant that the Department of Mental Health qualified for through FEMA. It's a statewide resource, and the Trauma Center and I think you've hit the nail right on the head, that not every provider is equipped to do trauma work with other providers. And the advantage of having a trauma center here in Massachusetts with skilled clinicians whose entire career and focus and training and continuing education is designed around providing that trauma response in a way that's sensitized and meets the needs of all comers, including providers. So they've been trying to reach in to different communities and schools and professional groups to make sure that people know that their resources are out there. We have a link to it on the DMH website. There is both a self-help, self-check webpage that people can use to determine if they might be more at risk right now of experiencing a trauma response or symptoms of other mental health conditions. And there's also the call center line for that particular mass support. I think the important takeaway here, and I'm sure it won't surprise any of you, we tend to see that professionals, particularly healthcare professionals, often wait quite a long time before they seek help for themselves. We make it our point to be there for everybody and to take care of other people. And it's really important that we get the word out that help is there for all of us too. And we actually start talking about the impact to healthcare providers. I appreciate your question. It's really timely and really important.
So Kim has put the link to the massupport.org through Riverside Trauma Center in the chat. It's a great program. I saw Barnstable County Health Department did a presentation with Riverside a few weeks ago for for the general population, parents, caregivers, providers, and I thought it was a really great resource. So I'm glad we're finding out more about that. Yeah, so thank you all. I see Kim put that in the chat. I don't know if anyone has any more questions for the commissioner. I'm glad to hear that the department is sort of monitoring telehealth, because I'm really curious, kind of in a universal way, globally, what the impact of the pandemic is on providing care generally. So it's interesting to hear how people have been able to use telehealth, and actually as a patient too, for the various appointments I've had to do by telehealth. You can compare for yourself how effective a telehealth appointment is compared to an in-person appointment. So I think that's so important to be monitoring as we go forward and hopefully come back to some sort of normalcy. So I appreciate you including that. And I don't see any more questions. So Commissioner, I really want to thank you for the time today. I appreciate your being here and sharing that with us. And I know we'll be checking out those slides and following this roadmap as it goes into the future. Our speaker next month actually will be Dr. Ken Duckworth, who is the medical director for NAMI. And I think he'll be talking about this as well, and about what he's seeing as a doctor in the pandemic, and what he sees for the future with this post-COVID stress that we're seeing, and the impacts on behavioral health. So, Commissioner, thank you so much. We really appreciate your time.
Thank you. I really appreciate being here today, and for my South Shore NAMI friends have been very generous in reaching out to me and including me in things, and I really appreciate it. Thank you.
Yeah, thank you to Liz and Kathleen and Sheila for engaging with you and having you come and present to us today. We really appreciate it. And Tyra, of course, who was on our board as well. So we're glad for her involvement too. So thank you. We do have a little bit more on the agenda. I want to turn it over to Blake at this point. Blake is from the Plymouth County Extension, and he's got a project that's going on, and he's looking for some participation by the group. So Blake, I'll turn it over to you.
All right, thank you, Mark. So my name is Blake. I work with Plymouth County Extension, And we're putting together an interesting project that we would like to have your help on. One of the things that is kind of front and center when it comes to the level that the type of education I deliver around the county is education surrounding vector-borne disease. So ticks and mosquitoes, things about Lyme disease, trying to prevent people from contracting these nasty bug-borne diseases. And one of the things that kind of came up, and is kind of really, I've been doing this for about 4 years, and in general, I give about 100 programs a year, and average attendance is anywhere from like 20 to 30 people. So we do reach a fair amount of people with these programs. And the numbers look good, like I get a lot of good feedback and so forth. But one of the things that has really kind of just been like playing around in my head and really kind of toying with me is this actually changing behavior? Because we all know that that's the most important thing. Is you can say that you've spoken with a number of people, but if you're not actually doing anything and then people aren't actually responding to your programming, then what does it matter if you've given programs to thousands of people? It doesn't actually make a difference. So I actually ended up kind of partnering up with Cornell University, and we've kind of put together this survey that I'd like to distribute to people around the county. And what we're looking to do is collect a baseline. This is going to be part of a much larger program. So we're looking to collect some baseline data for what people know around the county surrounding tick-borne disease. So for this round, it's just going to be concerning ticks, not mosquitoes. So we're really asking for your participation in distributing the survey to as many people as possible, just because the more people we get, the more we can really understand where are some weak areas in the county, how much do people know and do not know. The survey, I have to say, it's going to take about a solid 15 minutes. So it's not this like quick survey. We wanted it to be shorter, but what we're really looking to do is collect the most comprehensive data set possible. So I know that it's a little bit of a drawback making it longer, but we're hoping that people will still kind of put in the time to help us generate that good, strong data that we can then use to, really streamline our programs, kind of serve our county a little bit better. And then what we're actually going to look to do is follow up this survey with a number of other types of programming, educational materials, and maybe some pre-post tests, maybe some focus groups and things like that. So we're really looking to make this a much bigger project, but it all starts with this first initial push to get this survey done. I do have a link to the survey, and I'm going to go ahead and put that in the chat. Again, you can feel free to distribute this link to anyone you know. Even outside the county, those responses are still really useful, but within the county, we're gonna mostly focus on. One sec.
Blake, I would urge you to make sure you email that to Kim as well, so we can send it out to all of our members, because there's plenty of folks who aren't on here today. So
yeah, absolutely.
Yep, CHNA23@gmail.com is the email address.
Okay. And so yeah, that pretty much kind of sums up all I really needed to say. I mean, we're really, like I said, really this hasn't been kind of done anywhere else, because we really, these kinds of tick-borne disease education programs, they really only exist in Plymouth County and Barnstable County, and some New York has a couple, and they're very rare. So a survey kind of demonstrating whether or not these are actually working. This is kind of new stuff, and I think we're actually looking to publish.
Great. And what's the time frame that you want to get surveys back by?
We're looking to get the survey back by March 20th. So we're trying to give people about 10 days to do it. And honestly, it's only because the student that I'm working with at Cornell, her graduation date is in April. So we're looking to compile this and get some analysis conducted before she graduates.
Perfect. All right, great. Thank you so much, Blake. We'll definitely send that around, and we do urge everyone to take a look at that and share that with as many folks as possible. Awesome. Are you going to put it on social media, Blake, or what's the plan there?
Social media is fine. I actually have I can generate some more links for social media, and also email. I can email people directly as well if people want to just provide their email. But I know people can be a little touchy about doing that kind of thing.
Awesome. All right, thank you. We'll definitely send that around and probably put that up on our Facebook page as well.
Thank you very much.
I do have one announcement. Yep, I do have one announcement before we get to more announcements. Kim did send around yesterday the Health Literacy Award nomination form. We were gearing up last year around this time for our third annual Health Literacy Award. But unfortunately, we were sidelined, as so many things were, by the pandemic. But we are raring to go for our third annual, except for last year, Health Literacy Awards, which we will be doing virtually in June. And the nomination form, Kim did send it around. So check your email on that. And she's got it in the on the website, which she just
On
put
our
in the chat.
website,
Thank
yeah.
you, Kim. Yep. So yeah, we're looking for folks who have made an impact in the region on spreading the concepts of health literacy, empowering people to be able to advocate for themselves and for their own health, sharing accurate information, and working with providers to understand what their role is in sharing the concepts and promoting concepts of health literacy. So it's a really big theme for us. It's really important. We've had, actually, Teresa was one of our winners. I don't think Teresa's with us anymore. She was our winner back in 2019. So we're excited to have her today. It was a great ceremony. We had breakfast. We all saw each other. We were in one room together. Remember those days, those fun days? So yeah, so please do take a look at that. If you think of a worthy candidate, let's send it along. We want to have a great ceremony in June for that. Are there any other announcements? You can raise your hand or just feel free to unmute yourself. I don't see anyone. I know Kim has sent around a few emails today with new announcements from the things that are happening. So please do take a look at that. And thank you again to Commissioner Doyle and to Jennifer and Rose for coming back and talking about their mini grant. And we look forward to seeing you all in April. So thank you all and have a great day.